a pleasure to be here, and I always enjoy these echo sessions. We have a relatively small group today, which I think is going to be great so that we can have a robust discussion. So we're going to talk about COVID testing and specifically how it applies to children with medical complexity. I don't have any disclosures, and the views presented do not necessarily represent the views or opinions of the AAP or the board of the AAP. Next slide, please. So I use this disclaimer whenever I talk about COVID-19 because the information explosion continues to happen daily. We get changes from the CDC and other bodies about guidance pretty much on a daily basis. So just keep in mind that whatever you hear today may be outdated by the end of the time I talk, by the end of the day, or by the end of the week. These are the best places to get most up-to-date information. Of course, the AAP website, CDC website, and the World Health Organization website. Next one, please. So I want to start by reminding us that for all of these tests that we're using to diagnose SARS-CoV-2 virus and to diagnose COVID-19, the disease, all of these tests are approved by an emergency use authorization, not by the usual process. This means that clearly, these are tests that have been developed within the last 9 months or, less than that. There are literally hundreds of tests, diagnostic tests, that have been approved under emergency use authorization because we need the tests. But because these are emergency use authorizations, it also means that we don't have a lot of comparative data and we don't have a lot of testing of these systems in the real world. So just keep that in mind. The Food and Drug Administration can make available unauthorized treatments or diagnostics based on limited data during a public health emergency. Who decides when it's a public health emergency? Well, that's the Secretary of Health and Human Services. And that's the Secretary says when the circumstances exist. Now, keep in mind, emergency use authorizations go away after the emergency goes away. So all of these companies that have these diagnostic tests will have to submit more data to the FDA in order for the test to continue after the COVID emergency is over, which doesn't look like it's going to be that soon, but keep that in mind. Next slide, please. So what kinds of tests do we have? So, one of the gold standards is simple viral culture. And that tells you for sure, is there live virus within a person? These cultures are not generally available, and they would require a biologic safety laboratory at level 3. So these tests are being done in research settings, but they're not available for the general public. So what we have is kind of the next best. And some people would say maybe even better, because the PCR testing may be even more sensitive than viral culture, since not all viruses will grow very well in the media that we use. So these nucleic acid amplification tests will detect pieces of the viral RNA, or if it's a DNA virus, those pieces of the genetic code. And this is the preferred test for the diagnosis of COVID disease. However, we need to remember that these tests are extremely sensitive. They detect really, really small amounts of viral particles, and not even intact virus, but viral particles. And that means that they can stay positive long after the virus is gone. So long after a person has recovered, the PCR test may still be positive. Antigen detection tests are something that we got very used to when we were thinking about influenza and rapid diagnosis. In general, these tests are quicker than the PCR tests, and some of them are actually point of care tests that you can do right in your offices. But in general, antigen detection tests are not nearly as sensitive as PCR tests. Now, many of the companies will claim that these are very sensitive tests, but remember, there haven't been comparative studies. And we know from our past experience with influenza that many of the influenza antigen detection tests are only about 50% sensitive. So we don't know exactly how sensitive and specific these antigen detection tests are going to be. Because they are less sensitive, some people have actually suggested that if the antigen detection test is negative, the result is negative, you should follow it by a PCR test to really be sure that the person is not infected. If the antigen detection test is positive, then that says that the person's infected. We're not worried about false positives. We're really worried about the false negatives. Next slide, please. Antibody tests will tell you not whether a person is currently infected, but whether they've been infected in the past and made an antibody response. So this is prior infection. Remember that you make immune response to various viral antigens, so the different antibody tests that are available may measure antibody to different viral antigens. We expect the antibody test to be negative early after the infection because we know it takes you time to make antibody. So generally 1 to 2 weeks before you're going to see that antibody appear. What we still don't know is how protective is this antibody and how long will that protection last. We're still learning that. We have good reason to think that the antibody probably is protective based on the fact that we're not seeing a lot of secondary cases. And in the few case reports of second cases, there's been a change in the virus. So we think the antibody is protective, but we have no idea how protective, and we don't know how long that protection will last. So the antibody tests are really used for public health surveillance, and of course, for vaccine development. We want to know that the vaccine will help you make antibody, and it's really, that's the purpose of these tests. The exception to that is when you're talking about the multi-system inflammatory syndrome in children. In that case, we think it's an antibody-antigen mismatch, so looking for antibody is appropriate in that setting. Next slide, please. This is a nice graph that was taken from an article in the Journal of the American Medical Association. And this gives you a timeline. And I think it's a nice timeline because let's just kind of go through this. So we're talking about before symptom onset. That's the gray area of the slide on your far left. And so you've been exposed. And then at some point after your exposure, you begin to have the presence of virus in your nasal PCR. And that's the light blue line. So you can see that virus appears even before you develop symptoms. And of course, in asymptomatic people, it just appears. And then that PCR test stays positive for literally weeks, so long after live virus is gone. Then let's look at virus isolation from the respiratory tract. So this is isolation, and that is this orange bar. So the virus is present before symptoms, peaks around the time of symptoms, and then drops off generally within a week. So the time of virus shedding is about 10 days in most cases. We know that viral shedding can be shorter and also can be longer in immunocompromised patients. If we then look at some of these other lines, the yellow line is PCR in the stool, and you can see that stays positive for much longer. Then look at the dotted lines. The dotted purple line is IgM antibody, which generally is made a little bit before IgG antibody and falls off over time. Now, this is, in the usual case, but remember there are outliers. In some people, the IgM may stay positive longer. In others, it may be go down to negative sooner. And then there's the IgG, which is the dotted green line. That comes up about a week or two into your illness and hopefully stays up for a long time. We don't know exactly how long that's going to be. So antibody detection here is going to be later. PCR is likely to stay positive even when you already have antibody there, just because this is such a sensitive test. Next slide, please. So let's get to who should be tested. So we're going to want to test patients with symptoms because we want to make a definitive diagnosis. Who's got COVID-19? And the symptoms, take a look at them. Fever, chills, cough, congestion, aches, fatigue. Those are pretty non-specific symptoms. About the only really specific symptom is loss of taste or smell. The others are flu-like illness, symptoms we see in children with a variety of different infections. We also recommend that patients who have symptoms and are thought to have COVID-19, and even if they test positive for some other respiratory virus. So you do a respiratory panel when the patient comes in, it's positive for influenza or RSV. The recommendation is you should still consider testing them for COVID-19 because we know that co-infections are pretty common. And that has varied dramatically on the series from as little as 2 or 3% to as high as 30 or 40% may have co-infections. How you decide this is really going to be guided by two things: your clinical judgment and how prevalent is COVID-19 in your community. So if you live in an area where there's very little COVID-19, then your testing is going to be much less likely. However, if you live in an area that's currently a red area, a hot zone, then you're much more likely to be looking for COVID-19. It's also now recommended that patients who are in close contact with a confirmed or probable COVID-19 infected person should be tested. And the definition of close contact was recently changed. So the current CDC recommendation is you're within 6 feet of someone who has COVID-19 for a total exposure of 15 minutes, and it's cumulative exposure. So if you were with them this morning for only 5 minutes, but then, oh yeah, I forgot about that 10 minutes I saw them in the afternoon, that together gets you your 15 minutes of exposure. So these people who are in close contact, you want to test them to see if they've been infected, because we want to detect asymptomatic people because we want them to stay quarantined and isolated. So who is in, when do you do this? So the time of when you do this is not immediately after the exposure, because a negative test is pretty meaningless at that point. What you're looking for is 5 to 7 days after exposure, so that if the test is negative, you feel a little more comfortable that that person isn't, well, you know, they're not shedding the virus at this instant in time. But remember, they could still become positive. So the negative test does not get you out of isolation. It's simply to try to identify positive people earlier so that we can do better at keeping them isolated from others. And then we also want to test people who are scheduled for an invasive procedure or hospital admission so that we can appropriately isolate them in the hospital setting. Next slide, please. What about sports, school, work, travel? So let me start by saying there is no uniform guidance. This is going to vary depending on what setting you're in. So in one locale, it's going to be the recommendations are going to be different than another locale. And it's something we don't like. We'd like to have, uniform guidance, but in this scenario, it would not be appropriate. Remember, a negative test doesn't mean it's safe to return to activity. The negative test just says at this moment in time, you're not shedding virus, or at this moment in time, someone did a lousy specimen and it's a false negative. So you can't be comfortable saying, okay, you're negative, you can go back to school. If you've been exposed, you have to continue that quarantine for the whole 14 days. Also, a negative test does eliminate the need for the cloth coverings, for face masks, and for physical distancing. I always call it physical, not social distancing, and quarantining as appropriate. So even though you're negative, you're still going to want to wear your face mask, and you're going to want to keep your distance because, great, you're negative now, but you don't want to be exposed. And remember, the face covering protects you as well as protecting other people. Next slide, please. So the timing of the testing. So we talked about this a little. Let me just stress, patients with symptoms, you want to do the immediate testing so you find out, are they positive or negative. PCR is the gold standard. Antigen test, if it's positive, that tells you the person's infected. A negative antigen test may require a PCR to really be sure that it's negative. Delayed testing should be done in those asymptomatic people who have had close contact, and you want to wait at least 4 days. Some people would say 5 to 7, continue them in quarantine. And then as far as further testing, if they develop symptoms on day 7, 8, 9, yes, that's when you want to test them. Testing is generally not recommended for indirect exposure. So that's a contact of a contact. So a contact of a contact is not a problem until the contact gets disease, okay? So indirect exposures generally do not need to be tested. Asymptomatic patients who previously tested positive in the last 3 months, in general, should not be tested because they may still have pieces of the virus there, but they're not contagious. And then as far as return to school clearance, if a person has previously tested positive, you're not going to wait until they're negative to allow them to go back to school. You're going to use the CDC and AAP recommendations for when you can stop quarantine or isolation. So in the patient who's positive and asymptomatic, you wait 10 days. And if they're still asymptomatic, they can stop their quarantine. In the patient or their isolation rather, in the person who's been exposed, they quarantine for the 14 days. But this specifically talks about previously positive. If you have symptoms and you were previously positive, then you wait at least 10 days. It has to be at least 24 hours after fever has resolved, and your symptoms have to be getting better, okay? And there are exceptions to all these rules, but these are the general rules. Next slide, please. So which test do you do? Well, the PCR tests, polymerase chain reactions, are considered the gold standard for acute infection. What's the con about them? Well, it requires a nasopharyngeal swab, which is very uncomfortable, particularly in children with complex medical conditions. And the other option is saliva, but again, collecting the saliva is not always easy, particularly in a child with complex medical conditions. The turnaround time is going to vary dramatically depending on your locality. So in some areas, you'll get the test back in the same day. In other areas, it's going to take more time. Remember, as I've said several times already, it remains positive for weeks after the infection. These PCR tests are generally more costly and access may be limited. There are lots of places where you can get PCR testing, but it really varies by locality. So in many places where the state says you can go get the test, they are not routinely testing children. So you have to call ahead and know who's going to do the tests and how they're being done. In some cases, they will allow you to get your own specimen. This can be extraordinarily difficult for a child with complex needs because you don't necessarily want the parent doing that. You're not sure they're going to get an adequate specimen. So there are all kinds of things that go into really testing of the children that you all are going to be taking care of. As far as the antigen tests, they're very useful for acute diagnosis if they're positive. Not quite as useful if they're negative, and again, may require PCR confirmation. Generally, you're going to get the results more quickly, and you can use a nasal swab that doesn't go quite up to the nasopharynx or an oral swab. As far as antibody tests, these you're going to be using to provide evidence of past infection, but they're not going to help you with the acute diagnosis. They are going to be useful in the patient with multisystem inflammatory syndrome of children. And they're very useful for public health and understanding the epidemiology of this disease. They're not a reliable indication of protection, so you can't use them to say, oh, okay, this child's positive antibody, they can go do anything, they no longer need a mask, they don't need a distance. We can't use them in that way. And the sensitivity and specificities vary depending on the test. And again, tests haven't been compared among tests. So we don't yet have that information. Next slide, please. So let's talk about the pros and cons of where you do these tests. So let's say your practice decides you're going to send your patients out to get their specimen collections and their testing. What's the pro of this? Well, you don't need space or supplies. You can send them for a gold standard, better test. There's many public health locations. There's less risk that you're going to have transmission in your office setting and less use of your personal protective equipment. What are the cons? Your families have to travel for testing. The test results may not get back to you. And those testing locales really vary greatly depending on where you are, and not all of them will test children. Next one. Go the other way. That one's back. There we go. Okay. What about if you decide you're going to collect them in your office and then you're going to send them to the reference lab for processing? Well, this is convenient for your parents and your families. The results are going to come back to your practice. You don't need so much training on the specimen collection as far as actually doing the test. You may have access to better testing, and there's no CLIA training that's going to be required. Cons, it costs money to collect. There's money for handling. There's maybe increased turnaround time. Potentially, you can have a shortage of the collection supplies. You may have to be the person reporting the results to public health, which is not so much of a con, but it's one more thing for you to do that you don't need. And you may need extra staff to actually do that processing to make sure that the specimens get to whichever lab that you're using. Next slide, please. How about in-office specimen collection and specimen testing? So this is kind of, for your patients, the ideal. And because you know these children with medical complexity best, your patients are going to love it if you can do both the testing, because you know their patients and the family knows their patients, and you can do the testing as well. So it kind of closes that loop. You know you're going to have the result. What are the cons? The tests that are available to you may be much less accurate than the ones that can be done in centers. It may require moderate to high complexity CLIA certificates, which are difficult and costly. There may be delays and limited supplies or rationing of the tests. You do have to report these results to public health. And unfortunately, payment may be, the payment in excess of cost is not guaranteed. So you may be spending more money and then you're ever going to get paid for that result. And if you have your patients waiting around, there may be longer visits and potential for them exposing more people in your office. Next slide, please. So what about the particular problems of specimens and children with medical complexity? Well, I'm sure that most of you have had a nasopharyngeal swab by now, and you know that this is not something that you're going to run to the front of the line, can I get my next test? It is very uncomfortable, and it's going to be very uncomfortable for children who can't understand why you're torturing them like this or feel like they're being tortured. In fact, the mid-turbinate swab is much better tolerated. So instead of going all the way up to the back of your nose, you're going to the mid-turbinate. It's a much more comfortable test. And that's a test that generally can be self-done. Saliva testing requires 2 cc's of saliva, and anyone who's tried to collect that know that it's actually a lot harder than it seems like it should be. And it may be very difficult to collect saliva from children who, again, don't exactly understand what you're doing. Blood testing, of course, is going to be difficult as well, whether you need 5 people to hold the child down for the testing. You know your patients, you know your families, their families know their children, so you know what is feasible and what is not feasible. Next slide, please. So what do you do with the test results? Well, one of the most important things you need to do is instruct patients and families to stay in isolation or quarantine until the test results are final. Many people think, oh, I went and got the test, now I'm fine, I don't need social distancing, I don't need a mask, I don't need anything. They don't even have the result of the test back. So the testing itself is not magical. It's what to do when you get the result. We need to be sure that we're notifying patients of both positive and negative results. And if a person is positive and symptomatic, they need to stay in isolation because they can transmit disease. So you want them to be isolated until they're afebrile for 24 hours without the use of antipyretics. At least 10 days have passed since the first symptoms, and their symptoms are improved. If they're negative and symptomatic, they have some other illness that's giving them those symptoms. So you want to isolate them until the symptoms are resolved or until you treat whatever the other problem is. If they're positive and asymptomatic, then they need to be isolated. The CDC says 10 days, but some local health departments are still requiring 14 days. Now notice that isolation when you're positive is different from quarantine when you've been exposed. So if you're exposed, you're quarantined for 14 days during that incubation period. If you're already positive, you're isolated because you're shedding virus, and that is actually a shorter time for most people. Next slide, please. These are additional resources you can go to get the guiding. The AAP has a document on guidance. Remember, all the AAP guidance documents are updated every 30 days. The CDC has a website. The FDA will give you much more information about emergency use authorization. Then there's, and the FDA has other things, and the Food and Drug Administrator calculator gives you resources that explain positive predictive and negative predictive values, which for those of us that are used to statistics are sometimes relatively easy. For me, they've never been easy. Let's go to the last slide. I think that's probably it.